So, hi. So let me share the PPT first.
Medical समोर लावली.
So welcome everyone. So good evening. So it's a pleasure to have you here for the second expert opinion symposium. This is under the aegis of Indian Stem Cell Study Group. We have two expert speakers here, Dr. Molina and Dr. Ridhi, who will be introduced by our moderator, Dr. Madhuban Joseph. And let me introduce the moderator first before going to the program. So Dr. Madhuban Joseph, she's working as a fertility consultant, a cosmetic gynecologist at Annai Velagani Medical Hospital in Tirunelveli. She has been a faculty at the Donald School of Ultrasound from Tirunelveli, secretary of NARCHI at Tirunelveli chapter, and also the faculty at IMA CGB courses, who was also the faculty at ISR Chennai Feticon and AVAL 2023. And her field of interest, among the others, being one of the cosmetic gynecologists. And she has done various courses in Germany and Singapore, Dubai. And so it's a pleasure to have you as a moderator, madam. So welcome again. So I'm leaving this space to you. So please.
Thank you. Thank you, Dr. Natesh Prabhu, sir. First of all, thank you for inviting me to be the moderator of this session. And as I would say, in the practice of medicine, I would say we have been moving towards this preventive medicine and regenerative medicine these days. Earlier, it was we are treating not earlier, even now, treating the cause and the symptomatic treatment like that. I think now we are more moving towards preventive medicine and regenerative medicine. And I also have a quite great interest in this field of regenerative medicine. And I'm very eager to listen to both the topics. Both are very interesting topics. And I'm just waiting to listen to the very great speakers here. So I'll just share the slide. So our first speaker for this session is Dr. Molina Patel. And ma'am is here to talk on patient selection criteria to adopt regenerative therapies in aesthetic gynecology. And ma'am is the consultant obstetrician, gynecologist, and infertility specialist at Akansha Hospital, Gujarat. And she's also an assistant professor at Sri Krishna Hospital and Research Center at Gujarat. And madam has done her fellowship in cosmetic gynecology, and she has done a diploma in reproductive medicine from Germany. And also she is a certified Indian menopause practitioner. Welcome you, ma'am. Over to you.
Thank you, Madam Dr. Madhu ma'am, for this kind introduction. And I would like to, first of all, thank the Indian Stem Cell Study Group Association for organizing this symposium. And it is a great privilege and honor for me to be co-speaking with my role model, Dr. Ridhi Shukla ma'am. So without much delay, I would like to just share the screen and begin the presentation. Yes, so the topic that I have been allotted is the patient selection criteria to adopt regenerative therapies in aesthetic gynecology. Actually, it's a very, very narrow topic, but I have tried to include the patients that I have commonly done in my practice and what criteria that I follow. So we all know that in every phase of a woman's life, the feelings and experiences that a woman holds about herself, her body, largely varies with the socio-cultural and emotional and biological aspects. And the woman's perception about her own body constantly keeps changing with time. And these unspoken problems are often looked, or rather not even given a thought, So fluctuations in sex hormones, trauma from childbirth, ignorance towards nutrient supplementation, lack of adequate rest, and physically and mentally strenuous lifestyle and genetics per se are a few factors which make women vulnerable to alterations in the genital anatomy and functionality with age. So broadly, the most important selection criteria are all women who experience changes in their biological clock, who experience changes in their genital anatomy because of all these factors. So we all know what is aesthetic gynecology. It is an entire field that deals with improvement of the cosmesis as well as the functionality of the female genitalia of any age group. So young, perimenopausal and postmenopausal. So any woman who wants to improve her genital cosmesis and functionality are broadly suitable to get all these treatments. We all know that now regenerative medicine is being integrated into this field of aesthetic gynecology, and any therapy that includes growth, at least 2 out of the following 3, that is growth factors, cells, or a scaffold, comes under the criteria of regenerative medicine. So here, the most important application of regenerative medicine in aesthetic gynecology is the use of PRP. We are all doing a lot of PRP in gynecological infertility practices, but here specifically in aesthetic gynecology. It also has this integration, it leads to the integration of regenerative medicine in aesthetic gynecology. So the cells include the platelets, the growth factors that these platelets when activated release, and the scaffold is formed by the plasma that contains the cells and the growth factors. So we know that a lot of growth factors are involved, including platelet-derived growth factor, VEGF, fibroblastin growth factor, androgenetic growth factors, and all of them, when they are present in plasma, PRP qualifies to be termed as a good medium for regenerative medicine. So first of all, whenever we are selecting our patients, it is very important that we counsel the patient regarding the benefit of that particular treatment, the pre and post precautions that the patient has to take, the safety, specifically solutions like PRP are pretty safe because it is autologous and it is simply isolation and re-injection. The question is how you are going to evaluate the subjective effect of your therapy on the patient, and what other therapies like physiotherapy, TENS therapy, pelvic physiotherapy, which you could be doing along with these regenerative treatments to improvise the outcome. So the first patient selection criteria would be those desirous of vaginal rejuvenation. We have to make sure that the patients do not have any active form of bleeding or any unknown genital bleeding, no signs of active infection. If they so a per speculum examination is done for everyone, and if there is any prolapse according to the POPQ classification, we must classify the prolapse also, and grade 1, grade 2 prolapse can be easily evaluated during regenerative medicine. The more worse the prolapse is, you will not select those patients. They will be directly taken for surgery. So patients who have vaginal dryness, who have vaginal laxity, who have painful vaginal intercourse, who have urinary leakage and urgency, complain of vaginal looseness, particularly after their delivery, and who complain of vaginal sensitivity and labial pain, or vulvodynia, what it is better known as. So all these are our selection patients which we can subject to these therapies. The second criteria are the ones who have urinary incontinence, like from our patient, which we have performed, selected 120 patients over a period of 3 years, and we have selected patients between 45 to 65 years who have mild to moderate SUI, who are ready to give consent for your therapy, who have a positive stress urinary incontinence or neurodynamic study. Their pap test is normal, there is no active urine infection, and their vaginal canal and suburethral anatomy is grossly normal, no growth, no bleeding, polyps, warts, nothing, and they have a positive cuff stress test. So these are, again, could be used as criteria for selection of patients of SUI who are desirous of these therapies. Patients who have severe degree of pelvic organ prolapse, stage 2 and beyond, you will not treat for these regenerative therapies, because it is more severe and you need a much more one-stop solution, and surgery is definitive for such patients. Patients who have a transvaginal mesh Actually, this particular criteria is more applicable for use of energy-based devices along with along with regenerative therapies. But individually, if a patient has mesh, I guess PRP can be easily injected and used. Patients with photosensitivity, HPV, or any other vaginal infection, uncontrolled diabetes, previous, pregnant patients and breastfeeding patients. Breastfeeding is a relative contraindication. If they are having lochia, you will not do it. Otherwise, you can do it. Histology findings suggestive of malignancy again should be deferred. Patients who are not ready to come for follow-up or take post-treatment instructions well, and patients who are ready to have a realistic expectation. So these are the ones you are going to take, but grossly the undiagnosed bleeding, the severe prolapse, these are all patients you are going to outright defer and not select them. So patients who have had traumatic vaginal deliveries or instrumental deliveries, prolonged labors, or a high good weight of the baby and kept at the pelvic region for a longer time, leading to some amount of suburethral hypoxia at the time of second stage of labor. These are the patients whom you are going to select for these therapies. The third kind of patients whom we select are the ones who have menopause or perimenopause and they suffer from genitourinary syndrome. This is a recently coined term which was coined in 2014 by the North American Society, and it deals with these changes of anatomy and functionality because of genitourinary issues in aging women. It's pretty common. Almost 50% of patients entering menopause have some or the other form of genitourinary atrophy. And this is a collection of vaginal dryness, burning, irritation, or simply non-specific sexual symptoms like lack of lubrication, impaired intercourse, patients who are not able to have intercourse, urinary incontinence like urgency, frequency, SUI, and recurrent urinary tract infection. So these are again all the patients whom we are going to select for these treatments. Surgically, patients who are desirous of improvement in their function, that is vaginal tightening, sexual gratification, lichen sclerosis, and vulvodynia and SUI, which we have already discussed. Anatomical improvements like labioplasty, hymenoplasty, clitoral hood reduction. So basically, any form of regenerative medicine, whether it is stem cells or whether it is PRP, can be combined along with a surgical procedure also to improve the healing and efficacy. So when we talk about specific use of PRP for vaginal rejuvenation, we know that it helps to improve the vascularity of the recipient vaginal tissue. It stimulates type 1 and type 3 collagen, and it also helps in regeneration of the nerves, thereby improving the better sensitivity for intercourse and sensations. So when you inject this PRP in certain particular areas of the pelvic region, they also get converted to intimacy injections. So this could include injection in the G-spot. So this is a term that is being patented by Dr. Charles Runel in USA, which is known as O-shot. And we must, send our gratification to him for coining this term. It is a condition, it is a procedure in which the patient is fingered, the G-spot is actually calibrated, and then PRP is effectively injected exactly into that G-spot, so as to kind of augment the sensitivity of that collection of nerves present at the G-spot. Apart from this, PRP can also be injected into the clitoris, which helps in better sexual gratification, and in the clitoral hood, which is as demonstrated, about 0.25 to 0.5 ml of PRP could be injected in the clitoris to help in better orgasm as well as better lubrication and gratification during intercourse. Again, for these patients with platelet dysfunction syndrome or thrombocytopenia, so any platelet autolytic syndromes you are not going to include. Apart from that, relatively patients who are having hemodynamic instability, any form of sepsis, hypovolemia, recent illness, or any sort of bone or blood cancer, a low hemoglobin and low platelet count, these are all the patients whom you are not going to include in your selection criteria. After the treatment is done, patients must avoid intercourse for 2 days to help deal with the initial soreness of all these injections. Plenty of oral liquids are taken, and intravaginal hyaluronic acid, vitamin C supplementation. Basically, certain therapies can be started to, you know, sort of medical therapies can be started to improve the efficacy of our intimacy injections. So this is our data and the various kind of patients that we have selected for these therapies. Patients, you can see, are age-wise and indication-wise distributed in this table. So first 50 patients that we did, the younger age group, most of them were having post-delivery laxity. So this is again another class of patients whom you will select after the delivery. Second decade, 31 to 40, the third decade of life, it is a mixed bag having GSM, vaginal dryness, vaginal atrophy, as well as post-delivery laxity. Between 41 to 50, so these are the patients entering perimenopause. So these are the patients who now have majorly genitourinary syndrome of menopause, and after 60, most of them are having genitourinary syndrome of menopause. The other group of patients in which you could also integrate PRP and stem cell therapy is in the treatment of stria gravidarum along with your laser. So such patients who come to us, so this is stria albicans, old stretch marks, very severe and varying in length and width. We can put some anesthetic gel, and along with our laser therapy or whatever energy-based device that the various clinics in aesthetic gynecology practitioners are using, along with this, we can also inject PRP. There is a video actually. You know, because of the paucity of time, we could just skip it. So basically, this is a video of me giving laser to these patients, but we could also inject PRP along with the laser therapy, and that would be also wonderful integration of aesthetic gynecology in the treatment of these conditions. You can see these marks are created, which are actually our injury that we are creating over the stretch marks. And then we could actually also inject PRP about 1 to 2 ml along the various, along a small segregated area of that you are treating, because this particular patient has a huge surface area. You might be requiring actually a lot of plasma. So you must inform your pathologist or your technician in such a way that you want the platelet concentration to be done in a particular amount of plasma to include more amount of plasma. So this is all. With this, I would like to end my presentation. In my practice, as we have discussed, I am including all these patients of genitourinary syndrome of menopause, post-delivery laxity, stretch marks, intimacy injections, urinary leakage, vaginal rejuvenation, and easily integrating the use of PRP along with the energy-based devices that I have at my center for the effective treatment of these before mentioned conditions. Thank you.
Thank you so much, ma'am. That was really crisp and a very neat presentation. I just have a question, ma'am. Do you always do pap smear before doing any vaginal rejuvenation procedure for all cases?
Yes, definitely.
Or even for like any age group? It's
so
like
if they are hysterectomized, we do not do it. And if they are more than 65, we don't do it. But other than that, we do it.
For all cases, before doing any vaginal rejuvenation procedure, you routinely do it.
Yes.
Okay.
If it has not been done in the past 1 year.
Yeah, right. Okay, thank you. I'll just check whether there are any questions.
Madam, should we wait?
Shall we have the questions, question answer session now, or we'll move on to the next topic, sir?
The speakers, because Dr. Molina has to wait. Is she waiting, or shall we keep it? Because Dr. Redhi Shukla is sure waiting. Shall we keep the Q&A at the end? Dr. Molina, can we wait for some time till Madam finishes? Okay, fine.
At the end, yes.
Then fine.
Okay, fine. Please, yeah.
Fine, then I will move on to the next topic now. And
now you have to allow me to share my screen.
Yeah, ma'am, sure. I'll just introduce you by that time. Kindly allow me to introduce you. Thank you, ma'am. It's my pleasure to welcome Dr. Redhi Shukla, ma'am. Ma'am is the director of the Arogyam Specialty Hospital, GKSF Eurocare, and she is also the medical chief consultant at Ahmedabad University, founder of Nari Health Cafe Foundation, working for women health and awareness of society, founder of Women Vitality Vulva Clinic, pioneer in the field of cosmetic gynecology, and I'm happy to welcome you, ma'am. And ma'am is here to elaborate us on how to optimize the apt regenerative aesthetic solution for the patient, because we have a lot of options here. Which particular treatment to choose to which patient is really a confusing thing for us. So ma'am is here to discuss about it. Over to you, ma'am.
Madam, I just want to add few words to the introduction. So recently I met Dr. Didi ma'am at the conference in Ahmedabad. The presentation was far excellent. So we all are waiting for a presentation here, madam. Please go ahead. Yeah, thanks.
Is my screen is visible?
Not yet, ma'am. You have to start sharing the screen first, ma'am. I think you have not done
Yeah,
that.
I did started it.
But I am not able to say it.
Is it seen now?
No, ma'am.
If you can send your PPT, then we can remote do from here, madam, if it is a trouble for you.
No, I think I can share the screen.
Screen sharing is actually not done, ma'am, yet.
Okay. Sachin le mokla. So it's coming as a share the screen in desktop.
Ma'am, in the Zoom.
Yeah, you can share in the desktop or you can share your PPT, madam. It'll be showing
Sachin,
option like this.
Hello, Gautam. I'm Bilal. Hello,
I mean, in the Zoom window, there is a green icon called share screen. First just click.
Yeah, that's what I have done.
Either you share the whole screen or the PPT, ma'am. Anything is fine.
Is it seen now?
Not yet, ma'am.
Should I email you?
Yeah, ma'am, please send me even on the WhatsApp. We'll do that. Anything is fine.
Email karna.
So meanwhile, I can interact with.
Yeah, can we have the question answer session until this is sorted out, ma'am?
Yeah.
Can we have both the speakers?
Dr. Molina, ma'am.
Yeah. So we have a question, ma'am. Virginity makeover, how effective is it?
It's pretty effective. Basically, we mean that by virginity makeover, it is known as hymenoplasty, and it must be done surgically. Nowadays, even so, basically, it's just a purse string suture. You have to examine the patient whether the hymenal caruncles are present or not. If the hymenal caruncles are present, then using a very thin absorbable suture, such as 40 vicryl or 50 vicryl, we could just take a purse string suture and kind of close the orifice. However, if it is old, like a really long time of sexual activity, and The vaginal caruncles are totally flattened. There is no particular volume available to sort of take the purse string suture. Then even certain collagen tissue sheets are available. So I got introduced to this through my plastic surgeon friend. They do have these commercial biological sheets which you can actually put at the vagina, and they resemble our hymen. So it's a very thin bio sheet, and that is sutured over the hymen, neatly taken over the peripheries, and that also gives a very good result. It can be totally when the patient is having intercourse after the healing of this surgery, it will give them exactly the same feeling as rupturing the hymen for the first time. So that way it's very, very effective. So definitely a virginity makeover, or hymenoplasty as it's better known as, gives good results, and it has to be done surgically.
Yeah. So these sheets, like whether they will get absorbed later, or
Yes.
what will happen to it after
Yes,
it?
they get absorbed, and it actually just contracts. So it doesn't act as such fibrose, or kind of, it doesn't fibrose. When you put it, it just kind of absorbs and shrinks the tissue and binds the canal like that when it heals.
Okay, okay. So again, the next question is, please explain on Barbie vagina.
So Barbie vagina is a very kind of a layman term. I would say it's a self-proclaimed term, and there is as such no established term like a Barbie vagina, but it's a version of a perfectly functional and a perfectly looking vagina, which includes a vagina that is having no issues. There is no infection. It is completely tight, lubricated, and it feels young. There is proper sexual gratification. So that is the functionality part, and the cosmesis or the physical appearance also is like a Barbie doll. So it's quite perfect. There is no pigmentation. There is no boils or infection externally, and it basically it looks pretty perfect, just like a textbook picture or perception of a Barbie doll. But having said that, there is no set definition or benchmark of perfection. It's very, very individualized, and for somebody it might be perfect, and for somebody it might be still flawed. So it is a very personal, perspective of what a Barbie vagina appears to individuals.
Yeah, okay, ma'am. The next question. Do we have any age factor in the selection of lasers versus PRPs?
So not that I know of, as long as the exclusion and inclusion criteria are met, that is, as we discussed, patients don't have any undiagnosed vaginal bleeding, they have a healthy vagina, no gross anatomical abnormalities, normal pap test, no very severe SUI, no very severe prolapse, any patient can be done. My particular oldest patient was 84 years old, in which she came to us, and she was, because she was 84 and very morbid, ideally she was a candidate of surgery, but we still attempted to do laser and PRP for her in the suburethral part. And we did almost 5 to 6 sittings of a CO2 fractional laser with combination of PRP in her suburethra almost 2 to 3 times. And she was so happy. I also have a video testimonial.
That was done for SUI, ma'am?
That was done for grade 2 SUI. And actually it was even, I would say, grade 3 SUI. She would have easily benefited with a tape, but we did not do it because her family members never consented. So even with the treatment, we went slightly overboard, gave them slightly few more sittings, and I never repeat my PRP more than once. But for her, we still did it for an extended time, and it actually benefited her, and she was off panty liners. And, along with physiotherapy and pelvic exercises, she did pretty well.
Great, great. And what is the role of exosomes?
So, personally, I do not have any personal experience of using exosomes. Also, exosomes are pretty expensive to procure. From what I
Can you please just tell what is exosomes? So much don't know what it is, then just explain.
So basically, exosomes are a kind of a biological material which are said to improvise and regenerate the tissue in which it is injected. And it has some healing properties, it has regenerative properties, and basically it's like a carrier of growth factors in very simple words. So they are genetically engineered also now, and you need special permissions to kind of engineer them and produce them in your own setup. Commercially, I'm not quite aware of how you can procure them, so I don't have any experience of even using them.
Okay.
But
Madam,
exosomes are
madam,
really
can I do
used
that?
for infertility. Yeah, sorry.
Please.
Yeah.
They are being used for infertility practices also to, sort of improve the aging ovary. Yeah.
Yeah. So what is happening? When do is a PRP, we activate the PRP to release the growth factors. So when it comes to exosomes are, as Madam told, they are the carriers of these growth factors. That means it is going to secrete those factors. So you culture the MS, it is mesenchymal stem cells, then you filter it off because these MSCs will secrete those exosomes in the culture media. So once you filter it off, then you take off the cells, then you take only those exosomes. Those are called as cellular vesicles. Those will act on the area of interest. This is to go around a legality of cell-based therapies because stem cells as such are not being advised or legal to use for some indications. So to overcome that, people take these exosomes and they claim the effect is more than PRP and is equal to the stem cells. Just want to add to that.
Okay. And we have another question, ma'am. How many times we can do an O shot or P shot or whatever? How many? Any time number of?
So again, that is very individualized. But personally, in my practice, I normally, for many patients, I have observed rather that when we are injecting or doing the O shot for a patient, it generally keeps them going for about 10 months on a minimum. And then they do come to us, they come to us themselves. So I feel when the patient comes to us, herself, that is the time when you can re-inject, because she is her own control. What she had, the effect before it and after it, and then when it will go, she will know exactly when the effect is weaning off. So the good time to re-inject is when she comes back to you, which could be at the end of 1 year, 6 months, or even most of the cases by 10 to 11 months they come back.
Right. But what if they come very early, but whether we have to ask them to wait for some more time and it's not?
I don't think so.
Be
We
done
can do it
anything like
again
that.
because it's pretty safe. And I could have asked I can ask my senior experts regarding this, but I have not done it very frequently. But I don't think so. There should be an issue in doing it, say every 2 monthly or 3 monthly also.
Okay, fine. Okay. And how many sessions how many sessions do they usually need? That's, I think you've answered it already. With one session, she might be comfortable up to 10 months at least, right?
Yes, that is what I have observed. Yes.
Okay. So that's it from the Q&A. And if ma'am is ready, we can just move on to the next topic. Riddhi ma'am.
My mail.
Sir, have you
Nothing.
got a mail from Riddhi ma'am?
I received the email and I'm going to share the PPT once she's ready. Ma'am, you can start the video, ma'am.
Yeah.
Okay. So then you can share the screen.
Yeah, I'm going to do that now.
So once again, welcome, ma'am. Over to you. Very eager
Sorry
to
for
listen to
this.
topic.
Sorry for this trouble. Anyway, so very nice, Molina. She has spoke so many things like selecting the patients and preparing and inclusion criteria, exclusion criteria. But I'm sure that I'll also be able to throw some light on how to optimizing the solution for the patient. So, yeah, you may have to change the slide now.
Ma'am, you can change, ma'am. I have given the access. Just try once.
I am not able to.
It is showing as waiting for Riddhi Shukla to control his screen. Did you have to accept somewhere? Okay, bye.
Yeah.
I'll change for you, please.
So objective of today's talk is what is aesthetic gynecology, what is regenerative aesthetic, and how can we combine both to give a optimum result to the patient, and what are the applications of regenerative aesthetic in gynecology and urogynecology, sharing our experience, spreading awareness those who are new to the field, creating a platform and community, and updating my skill and knowledge, of course, as well. Next. Yeah, next slide, please. So, as we all know, aesthetic genital surgery is probably the fastest growing field within the all aesthetic surgery. These are the various, no, I may not go in detail, as Molina has already explained that what it is, but I just thought of putting it as some people might be new to the aesthetic genital surgery. So, it is these are the various names given to aesthetic genital surgery. It falls under the two categories: surgical modalities and non-surgical modalities. In surgical modalities, this is a labiaplasty, where there is a labia minora reduction or majora reduction or augmentation. Then there is a CHR, that is a clitoral hood reduction, surgical vaginoplasty, perineoplasty, and hymenoplasty. Next slide. Non-surgical modalities are laser, radiofrequency therapy, which is used for multiple reasons, and then other newer modality like PRP, Botox, filler, thread, hydration, and HIFU are used in a cosmetic practice like any other dermatology practice. Regenerative aesthetic, what I understand is it's an emerging branch where regenerative medicine with therapies are aid and recapturing the youthful structure and function using the body's own system. So you basically stimulate body's own system by giving them growth factor or a stem cells, or providing them the scaffolds. And difference between a traditional regenerative medicine and regenerative aesthetic is that here it is used for not for a disease parts, but for the aging parts, and to give the rejuvenation to the normal tissue. So next slide. So this is the basic distinction, and how can we use in cosmetic gynecology practice? That's what we'll see next. So when we think of optimizing the solution, I would say that we need to understand the subject, and then we have to see how we can apply these things in our practice. Like, I'm sure every gynecologist must be seeing lots of menopausal patients, lots of patients with mild SUI or a grade 1 or 2 prolapse. So initially there are certain therapies where no treatment were available, or for genitourinary syndrome of menopause, you were giving just estrogen cream. You were not able to help the patient, and estrogen cream, as we all know, it works only onto the epithelium level. It does not work deeper. So we need a better therapy to deal with these kind of problems of women, which we do see in our practice. So what we need to do is we have to understand that how this mechanism is work, and we have to apply it properly in our practice. Then we are giving the best result. Then I think you have to take a basic training. You should have to have at least an infrastructure of PRP to start with, and then you can upgrade to laser or radio frequency or HIFU or whatever. But to my humble request to all the gynecologists, that at least start doing PRP. PRP is a very easy procedure. You can do it in your OPD or in a consulting room. It takes very less time, and we being a gynecologist are very well versed with the vulva and vaginal anatomy. So it is who we are going to give this treatment to the patients, rather than sending patient to dermatologist or a plastic surgeon. We need to generate awareness amongst the patient as well as among the colleagues and doctors, because we need to tell patient that, okay, you have a mild SUI or a genitourinary syndrome of menopause, but nowadays there are newer therapies are available. And what I have seen in my clinical practice, that patients are, once you explain them about the PRP, that from your own blood, there are tissues which is not healing properly, and we are providing growth factors or a healing tissue to that part just by withdrawing your blood, preparing and injecting. And then I feel that the conversion rate or the readiness is fantastic. So what I understand, that you understand the subject, take basic training, talk to the patient, and tell them frankly that these are the newer therapies, these are the newer treatment which was not available previously, but nowadays it is available, so we are giving you this treatment. Developing a treatment protocol facing unique challenges, as I said, that laser, when I took my training, we being a gynecologist, we may do major surgeries and Vardheims and all that, but there's small one laser or RF, when you hold it in your hand for the first time, you feel very scary. Okay, dermatologists on the other way, because though they are not a surgeon, still they do laser therapy of the whole body. So it's about updating your skills and developing that mindset that, okay, you can do this therapy, selecting right patient and right procedure, and of course, right procedure for the right patient. Just because you have a laser, you cannot do laser to everybody, or just because you are expert in PRP, you cannot inject PRP at everywhere. So there are specific indications where you can use these procedures. Then there are, of course, sometimes there is a treatment failure or some complications that you need to manage. Developing IC and collaborative efforts. Training, I took my training way back in 2015 at European College of Aesthetic and Medicine and Surgery. When I went there, I could see that there is a totally different paradox in the world. There women are coming more for a aesthetic reason. When I came back from my training and started looking for applications of these procedures in my patients, what I found is in India, in country like it, there are many functional issues. Sexual pain, sexual problems, urinary incontinence, pelvic organ problem, menopausal vaginal atrophy. So these are basically functional issues, and you have to see that once you are trained, you can help women to regain their functionality. As Molina has rightly said, that aesthetic vaginal is not just the cosmesis, it is a cosmesis plus functionality, and we need not to be judgmental. Even if patient is coming to get vulva bleached or for a labioplasty, we have to be non-judgmental as a women healthcare provider. What I see in my practice, that we need there are certain issues of self-esteem where women do want to alter their vulva or vagina, so that's fine. So what I took training way back in 2014, spending lakhs and lakhs of rupees for 3 days, what I have seen is here we are easily able to give global training at a local level at various centers in India, where we can take training, we can teach people hands-on. So nowadays these things are not very difficult. So once you feel that, okay, you are interested, then you should opt for at least a basic training. This is how we teach everybody to perform a laser procedure on a dummy pelvis. So proper training is must to optimize the result. That's what I feel. Scope of aesthetic general surgery or regenerative surgery in your practice is, there can be absolutely cosmetic indications, there can be functional indication like physical, sexual or emotional, there can be psychosomatic issue or a mixed reasons generating patients. Then of course you are now trained, you have a machine, but you have to generate patients, right? So how can you generate patients? So review your current practice. What is your practice? Do you have a patients who are menopausal age group? Do you have a women, young girls who are falling in a PCOD, or there are mid-age women who have a sexual problem because of vaginal laxity? And then you identify treatment approach which have a regenerative potential. You have to understand mechanism of action of each and every therapy, whether it is a stem cell therapy, it is a PRP, it is energy based device, that how this is going to work. Then applying newer approaches in a you have to apply these newer approaches as I said, that genital urinary syndrome of menopause, we didn't have anything available, but nowadays, since last 7 years, I have lot many patients, old age women, more than 60, 65, on a laser therapy for their vaginal atrophy. They are doing excellent. Recurrent vaginal infection has gone, recurrent urinary tract infection has gone. So this is where we are improving the quality of life in a menopausal women. Then providing solution where, see, there is a grade 1 SUI or grade 1 pelvic organ prolapse. You cannot offer anything. You cannot offer transvaginal or TOT tape because it's too early. So there are certain disease where no treatment are available. So regenerative therapies are a solution to this. And you have to, as I said, that you have to develop an attitude towards this newer therapy. I think previous slide. So vulva and vagina are ignored part. Even in gynecology practice, we are doing transvaginal sonography and delivering, but hardly we are looking at the vaginal atrophy or any scars or any chronic itching on the vulval part. So these are the ignored part which needs a rejuvenation. And this is what we see in a GSM. You can see the healthy vagina and vaginal atrophy, high estrogen environment and low estrogen environment. Estrogen cream works only on the epithelium. When you are targeting all the three things, then the better newer therapies are the solution. There is a transition in vulvovaginal area because of age, because of the stage like post-pregnancy, or there are some comorbid condition which leads to changes in vulvovaginal area. So, as we know, there are 3 pillars of regeneration. Molina is very well explained. So stem cell in gynecology mainly used nowadays mainly for 2 reasons: ovarian rejuvenation in primary ovarian failure and for endometrial gratification in either Asherman syndrome or in infertility or a recurrent IVF failure or recurrent implantation failure. This is where the stem cell, I may not go in a detail of the therapy, how it is, because of the time limit. So stem cell is retrieved from a iliac crest or any other bone, and then they are prepared and then they are laparoscopically injected in a ovarian tissue. Initially, I have done couple of patients with a PRP, but now we are doing it with the stem cell. In last 3 months, I think I have done 2 patients with low AMH, and now we are repeating AMH after 3 to 6 months. Premature ovarian failure, yes. And nowadays I have said, because we are sharing what we are practicing, so I have heard that in metro cities, women, those who are entering in a 50s without any problem, just as an anti-aging process, they want their ovarian to get rejuvenation. So that's why they are getting stem cell injected, and endometrial gratification in, as I said, in infertility or Asherman syndrome, where a stem cell is used. This is a mechanism of action. We know that ovarian injury, chemotherapy, apoptosis, these are the reasons for primary ovarian failure. And when stem cells are injected laparoscopically through a needle in the stroma of the ovary, then the regeneration can be obtained. So this is how the stem cell is used in a gynec practice. Hysteroscopic instillation of stem cell or a PRP for infertility, endometritis, or Asherman syndrome. We all know that how platelet-rich plasma is prepared and then it is injected through hysteroscope inside the endometrial cavity. You have to make multiple punctures and inject it. PRP in gynecology for other indications: vaginal rejuvenation, SUI, dyspareunia, lichen sclerosis. I have so many patients of lichen sclerosis. Very good result of PRP. So it's in a true sense regeneration, where patients were kept on a steroid creams for years together. But now I have started doing PRP for lichen, and there are many patients having excellent result. Sometimes painful fissures, vulval leaching or dryness, or a chronic pain on a vulvovaginal region, where PRP can be used. This is how PRP is injected in a suburethra for a mild degree of SUI. Does PRP help in sexual gratification? What Molina has already talked about, G shot and O shot. These are the different shots used for a male, female both. That is called a P shot for a penile shot or a premature ejaculations, and G shot and O shot what we used for sexual gratification in a female. This is how PRP is injected. I have not personal experience of injecting stem cell or anything, but yes, I do injecting PRP in a intimacy enhancement or a sexual gratification, where we are injecting PRP on a G spot as well as on the labia minora and some area of in a suburethral region. So these are the very sensitive area where you can provide sexual gratification with the PRP. A scope of service using energy-based device, there are multiple in young age: vulval bleaching, surgical excision, vaginismus, imperforate hymen, or a vulval aesthetic. And when we talk about regenerative medicine in mid-age or geriatric, incontinence, pelvic organ prolapse, GSM, sexual pain, scar, warts, discoloration, or a Bartholinensis, this is where various energy-based device can be used. What I seen in my practice, that maximum regenerative therapy I'm using in a genitourinary syndrome, where there can be a vulvovaginal symptoms, sexual symptoms, or a urological symptoms, and having excellent result. Selecting the patient is a key to optimize the result. Offering desired result is healthcare providers' role. We have to accept the best possible result. Proper diagnosis and proper counseling is must. What you have to do is you have to offer a complete treatment basket, that okay, you have a estrogen cream, you have a PRP, you have a laser therapy, you can go for a pelvic exercise or a pelvic chair, and let them choose what is best for them. You just explain them this is the complete basket available. And whenever patient is coming, very important to optimize the result, what is their primary concern. Whether patient has come for a sexual reason, then try to treat them. If patient has come for a urinary complaint, then try to treat them. If patient has come for a vulvovaginal dryness, then try to treat them. Don't just try to treat everything at once. First, you have to address the primary concern, why patient has come to you. This is how you can make them happy, because their primary problem is sorted out with whatever therapy you think. This is how the laser is used. This is a CO2 laser. Molina has already shared their experience. These are the inclusion criteria which he has already shared. Exclusion criteria: grade 1 pelvic organ prolapse. Where I have highlighted it little bit red is till last 2 months I was using only in grade 1 pelvic organ prolapse, but I am a member of some other international group also who is practicing various regenerative and aesthetic practice. So there is a sharing happens. What I have heard and learned in last 2-3 conference, that even if grade 2 and 3 prolapse is there, when patient is not fit for the surgery, or because of the financial reason, or in Western world where hospital has to pay the bill, when patient is not planned for the surgery, they are still offering energy based device which is giving good result. So pelvic organ prolapse grade 2 and grade 3, these are the advantage, that this is a minimally invasive procedures. Treatments are generally lasting for 5 to 10 minutes. Very well tolerated. Usually there is a less downtime. You can perform under no anesthesia, and there are rare adverse event. Disadvantage: devices are costly. Treatments are not covered by insurance. Therapeutic effects are limited to sometimes in superficial vaginal tissue, and tissue destruction can sometimes leads to burns and injury when you are using laser. No, the previous slide. The previous slide. Nothing. The previous slide. So what I have seen is that whether, again, I would say whether you have any energy-based device or not, but PRP is a very easy regenerative therapy which has got a very good result. So many patients like an GSM, mild SUI, vaginal rejuvenation. So everybody should at least start with PRP What is required in clinical practice is consent form. It has to be customized preset protocol for patient evaluation, counseling, preferably recording, audio-visual, illustration-based consultations. Yeah, after post-COVID and during COVID, we all are very well with webinars and online consultations. And you have to give a disclaimer on every consultation paper. Whatever the therapy I am offering to my patient, I'm telling every patient that these are the newer therapies. Long-term results are yet to come. What I have seen in my clinical practice with good result, we can try in you. This is must. Then, with that acceptance, if patient is ready, then you get the optimum result. There can be a testimonial of one patient, video or written, which help. These are the various newer technique. Threads which is applied on the face similarly can be applied on a vulva and vagina. This is a HIFM chair, and then there is a HIFU machine for a whole body. These are the every time. Filler is not more of a regenerative, but this is just I have a kept that this is how it is used, and Botox is used for a severe degree of vaginismus or dyspareunia. What is our role is to generate awareness about the regenerative medicine as well as cosmetic gynecology, to emphasize on overall wellness. We have to deal with unspoken issues. We need to educate our patients about these newer therapies, and we have to offer latest technology to resolve sexual or unspoken issues of women's life. Selection of modality and procedure, right choice of procedure, right selection of patient for her need, right time to perform. You have to do pap smear in every patient. You have to rule out any infection. If any infection is there, you have to treat that infection. When you are using PRP, you have to see patients hematocrit value. You have to have a right infrastructure, right team, and right modality for your practice to optimize the result. And tips for practicing cosmetic or regenerative gynecology: you have to have a passion, you have to have a determination that okay, I want to try. Then you start learning, then you share your presentations or you share your cases with others. This is how you have to constant update knowledge. You have to constantly see what is the trend, what is going on. As I said that initially I was doing for grade 1 only. Now the trend is to do for grade 2 or 3, and there is a continuous upgradation of your skill with a roundtable meeting or focus group discussion or workshop. Whichever way, you need to have a dedicated mindset, dedicated time. You cannot do in your busy practice, but if you wish that okay, I want to do, then you have to have a dedicated time and you can do this. You have to reach out to the patients via bookmarks, social media, lectures, visual media. This is how we generate. I made a vulva model done locally once I came back from my training. This is a book of my patient story, which we are printing regularly with change, of course, with patient's consent, and we are changing the name. There are very beautiful stories of how we can help them to improve their functional issues. It can be her desire to have a beautiful intimate area, or there can be a discomfort. So we need to respect both desire as well as discomfort. This is a customized model which I asked some young girl to make. This is a vulva model, and we establish a vulva clinic. These are the bookmark to generate awareness or sensitize the patients. So brochures, bookmarks, various books or models you can use, and you can reach out via talk show or a conference, via training and workshop amongst your colleague. So we need to think out of box. It is upcoming branch. Mindsets are changing. Society is accepting. So what we have to do is we need to break our barriers and start practicing these newer field. And this is all about my presentation. I hope I could justify my presentation. Thanks.
Thank you, ma'am. Thank you so much for such a wonderful presentation, and also for encouraging the upcoming cosmetic gynecologists like us, giving your experiences and how to do it and everything. Thank you so much, ma'am. I have a question, ma'am. What is your personal experience about which energy devices to choose for which patient? We have lasers, we have HIFU, and we have radio frequency devices. Which one to choose for which patient?
This is a common question since last 7 to 10 years in every conference, and everybody is asking. What I am suggesting is every energy-based devices are very costly, right? So what you need to do is you have to see what is your practice. Okay. Suppose you are doing, and when you have to look for a ROI of your machine, then there has to be, suppose 4 or 5 gynecologists are ready to do, then you can go for a laser. Every energy-based device, the basic mechanism is same, formation of new vessels, new collagen, elastin, and it is a regeneration. So if you are practicing with dermatologist, then you can afford to have a HIFU where you are, or your practice is such where you can do offer a patient mommy makeover, like what Molina shows on the stretch mark and all that, then you can go for a laser. So basically you need to see that what is your practice, what is your potential patients, how can you do it, then you can start. But as I said, PRP is a very cheap therapy, does not
Start with PRP.
invest much. So at least start with PRP and try to focus that what kind of patients you are getting
Right.
initially. And if you have a laser, then you can do everything with the laser. If you have a radio frequency, you can do everything with the radio frequency. So I would say whatever you have, start doing it. You do everything with laser. Okay, you can cut, you can do vaginal rejuvenation, you can do vulval bleaching, you can do abdominal stretch mark, everything. Similarly with radio frequency, similarly with HIFU.
So what is our type of patient and what is our budget?
Yes.
Plays
Yes.
a role.
And is there somebody who is ready to practice with you? If dermatologist, then you can go for a expensive CO2 laser where you can do whole body. If you feel that, okay, you just have your small gynec practice and there are more patients of menopause and all that, then nowadays there are cheaper diode lasers are available which are costing between 10 to 12, 15 lakhs. And that also a small portable machine. So 2-3 gynecologists of your area can buy this smaller machine and start using that. When I started practice, it was long back in 2014. Not much options were available. So I had to buy a big CO2 machine and I had to invest a lot. But nowadays you have so much options.
Yeah. Thank you, ma'am. And I've got a lot of questions. Can I just go one by one?
Yes,
Dr.
yes.
Molina, are you available? Yeah, she's there. Yeah. Please. So first, a very basic question, ma'am. What is the difference between cosmetic and aesthetic gynecology?
It is the same, I feel.
Yeah,
it is
more or less the same. It's just different terms that
aesthetic is a big fancy word. And initially, it was a cosmetic and now it is aesthetic. But ultimately, I personally feel it is the same.
Maybe one is UK English and other is US English, maybe like that.
Maybe like that.
So what is the difference between plastic surgeon and gynecologist approach in aesthetic gynecology? Someone is asking.
See, plastic surgeons are very well versed with handling small size sutures and handling the tissue with a gentle care and all that. We gynecologists do just 2 surgeries, delivering 3 kg babies, rough and tough, or a hysterectomy, which is again a big surgery. So gynecologists are trained to coagulate and cut. Where in plastic surgery, you have to preserve every vessel or every tissue. Okay, so this is a basic difference, that plastic surgeons are trained or preserving tissue or preserving vascular supply to every structure, where we are trained to coagulate and cut. So what is there is, because I feel that gynecologists are very well versed with the vaginal and vulval anatomy. What is there is, you need to learn a plastic surgery, tissue handling, and a suturing, and then you can be the best surgeon, I feel.
Yeah, it's just like we have to become a little more gentle with the tissue.
Yeah, you have to be
that is the idea.
gentle.
Yeah. Okay, ma'am. The next question is when to combine lasers and PRP?
Again,
When we first do it, or and in which condition?
So when I went to my training, my mentor, Dr. Azadar, told me that once the patient comes, do everything. Okay. You do laser, you do PRP, you give best result. So I was doing both the things in combination since so many years. But since last 2 years, people have said that plasma and like PRP and laser both are working in a different mechanism. Okay, here you are hitting the tissue, there you are inserting the growth factors. So what I have learned from people who are expert of PRP and stem cell, well, Dr. Natesh is there, and there are so many people of stem cell and PRP therapies. They can again guide me. I'm here to learn. They have told me that you should not combine two together. So what now I have started doing is that I'm giving 2 to 3 weeks interval between laser and PRP. And broadly, I have a couple of patients where I have done 3 sittings of laser completely, and then I am offering PRP. So since last 2 years, I am not doing it together. Initially, I did it for 5 years.
So we'll do the laser and wait for the collagen formation, and then only do
Then
the
after
PRP after 2 or 3 weeks.
Yeah, this
Right.
is what I am doing.
Okay. So what is the cost of laser and PRP procedure they're asking?
See, laser therapy, initially, the machine came where all the disposable probe. So the probe were costing very high. So it started with a very high cost. But now we know that people are not ready to pay. And now all the machines have autoclavable probe. So if you have a 1 or 2 probe which you can autoclave, then your cost is going down. If the laser machines are cheaper, so basically, like we do C-section in general ward and suit room. Surgery is same, but you are charging different. Similarly, I charge somewhere between 7,000 to 20,000, depending upon patient's pocket.
Okay, ma'am.
Okay.
Fine. And the role of stem
10,000,
cells in...
I feel 10,000 has become standard everywhere. Molina can guide me, but what I have standardized is recently is 10,000 per session.
And this is for the lasers.
Yeah, lasers. PRP, we all know that tubes are available somewhere
Yeah,
between.
I have a doubt in that, man. There are so many like market available PRP tubes, which to use, whether we have, like we can make it by ourselves or buy the tubes from outside.
Rather than tube, your procedure is very important. Okay. So initially, again, I would like to share that I was doing a constant 12 minute at 3,200 RPM. Now, what I have recently learned is that you do it for a half time, then you use another tube to get a better result. So the tube which comes between 500 to 1,000, they are all the same. What derma people are using is come with the enhanced growth factors which they are using on the skin and all that. So if sometimes you feel that there is a severe atrophy and patient can afford, then you can go for tubes which are available somewhere between 1,500 to 3,000 again. But otherwise, tubes, majority of the basic tubes all are giving good results. So you can use any standard tube. When you are concerned about face, or what I've learned from some dermatologists is that they are using some enhanced growth factor tubes that I'm using in some patients where I feel that laser has not worked. If I want to do something, then I have done couple of times those higher growth factor tube. It has given a good result. So again, for 1 or 2 session, you can
Depending on the patient.
Yeah, depending upon the patient.
Okay. And role of stem cells in cosmetic gynecology, have already spoke about it in that presentation as well.
I have done only 2 things in my practice. One is I've injected, initially I was injected in PRP. Now I have injected stem cell in ovarian. One patient was a POF, primary ovarian failure, and second one was young, but still she is not married. But she's 45, so she want to preserve her fertility. So she herself is a doctor from Mumbai. I instilled 3 weeks back. She came here that, madam, before my ovary goes into a failure, so that we did. And in couple of endometrial patients. So in my practice, I am doing only gynecology. These are 2 things. Some people have done in spinal cord injuries and stem cell spinal cord injuries paraparesis or hemiplegia, those patients. So there are stem cell as a wider applications, but in my clinical practice, I have done only these two
In
pertaining to
gynecology, not in cosmetic.
not the other things.
Okay. So can we combine MCELA chair along with lasers or PRP?
See, MCELA chair is for a pelvic floor contractions. Okay, so when there is a mild SUI or a pelvic floor dysfunction, MCELA chair can work. But laser, when you are using inside the vagina for vaginal rejuvenation, which is stimulating the tissue, that cannot be done with MCELA anyhow. Okay, so if patient is having
Laxity part
primary,
of the
yes,
part of it.
pelvic floor dysfunction, then you can use MCELA chair. If patient is having vaginal atrophy, then you have to do laser or radio frequency. MCELA is not going to help.
Okay. And Thermiva and other devices, your
Thermiva is a radio frequency. What I said is, radio frequencies are much easier devices than laser because in clinical practice. But again, with laser, treatments are done in 5-10 minutes. But with Thermiva, you have to, or any radio frequency, it takes 40 to 50 minutes. You just have to sit and apply. So again, what I have seen is it depends upon your temperament. You are a kind of, bitter dashing person, or you feel that, okay, you can handle laser very well, then you should go for laser. And when you are scary, or when you feel that you have a busy OPD, you are leaving your treatment on a therapist or an assistant, then I feel that radio frequency are safer devices.
for maybe if you're starting with the practice, you mean to say radio frequency for this?
That is not possible because both are costing very high. So whatever you buy, you have to stick it to for next 10 to 15 years at least.
Okay. There is one very controversial question. Why is there a need to beautify private parts? Is it not a body dysmorphia issue? What is your say on it, ma'am?
No, the red book which I showed, where I've written a couple of my patients' story. One patient said that she was divorced because she had black patches on her vulva. So husband was torturing her a lot. Then she got divorced. She got remarried. The new husband does not have any concern about her private part. But she said, for my self-esteem, I want to get vulval bleaching done. So sometimes it for a patient's own self,
personal choice. Yeah.
sometimes for a partner's wish. So indications are various. And I feel that breast is also a natural part, face, everything is a natural part. But if somebody is not happy about it, and today because there was a time limitation and the topic was different, but otherwise I do have a presentation when there are more than 400 variants of vulval complex. Okay. There can be, I had one patient, she had one labia 7 centimeter and one labia minora was normal. So all the time the labia was hanging and she was feeling whether it's a penis or what. So she came to me whether I am normal or not. She was 25-year young girl with a hanging labia of 7 centimeter.
Yeah. So
here it's no more a body, it's no more a body dysmorphic organ. Okay.
Now, Dr. Molina, do you want to join us for the discussion, please?
Yes.
What is your say on this particular question, the last one?
I think I totally agree with ma'am because nowadays, because of awareness, and I guess because of all this social media and, women being more open about talking to each other also about their private issues, people know more now that what is normal and what is not. And especially they're more conscious and aware of at least their partner's requirement of them. And I feel if they want to kind of attract their partner by looking in a certain way, it's a personal choice, but that should also there should also be options available to her if she wants that kind of a thing from a gynec. So definitely we should provide her and make her aware that certain treatments are there. You cannot be, it's not a magic wand that, you can change everything. But definitely, so even, in parlors and salons, they are doing a lot of hair removal from the bikini area, and they're doing a lot of body sculpting, non-surgical body machines are there. There are all these-
Lightening, genital
Yes,
lightening.
exactly, body polishing. So these are all the packages which these salons are offering. Salon people, being completely non-medico people, are also giving these kind of therapies. It's like a menu card, body
Yeah.
polishing and waxing and hair removing and all that. So I think as gynecs, we should definitely do better than that.
Yeah.
So I think that from there is at a ground root level now, and the demand is there, I need to say.
At least as learned medico people, we can give the awareness to the lady whether what they are wanting for is realistically possible or not. At least they can have that awareness after coming to us. That's what I feel.
Moreover, as I said again, in our country, functional indications are very much, if there is a thick clitoral hood, she may have pain, or she may have to leave the skin sometimes for urination or during sexual intercourse to get orgasm. So these are the genuine things which sexual problems can be there because of abnormal, I would not say it abnormal, but variant of clitoral hood size or shape. So if they have a sexual problem, they do have a urinary problem, they have a functional problem. So I feel there is nothing wrong in offering, and in country like us, or what I have seen in my practice, that functional indication are many.
Earlier, women wouldn't come out and say all these problems. Nowadays, if it is their own gynecologist who delivered her or taken care of her for all these years, and if we are gonna do the same, like deal this these problems as well, and I think she will be more comfortable, right, ma'am?
Yeah.
And one question I missed, for anorgasmic women, what is the role of PRP?
See, you first of all, you have to tell patient that for female, it's not must to have an orgasm. Female can be happy or satisfied without orgasm, and she can have multiple orgasm. An orgasm, if it is bothering her, then only you need to treat her. Okay. You have to tell her that this is normal not to have orgasm. But if she wishes to have orgasm, then what I said is a sexual gratification. You have to ask patient to palpate and point out the area where she feel very much excited. This is the area where you can inject PRP. Plus, you can inject PRP on the labia minora. There are erotic zones on a intimate area. So you can ask patient to point out those areas. This is what we called is a intimate mapping. We ask her to map out the areas on her private part. And there you can, if you can inject PRP, then it does help in a sexual gratification.
Okay, right, ma'am. Thank you. Someone has raised the hand, Mr. Keshav Ramu. You want to ask something, sir? Have any doubts? Hello?
Okay, we can skip it, madam.
Yeah, okay. So anyone from the audience would like to ask any doubts? The floor is open.
Fine, madam. I think we can.
Yeah. So I think we can call it a day. And thank you so much, ma'am, Riddhi ma'am and Molina ma'am. It was really a great time for me, and I've got lot of practical tips from you both. And I've just started my cosmetic gynecology practice, and thanks for the encouragement as well, ma'am. Thank you so much.
Thank you.
Thank you so much, madam. Dr.
Thank
Riddhi
you so
Shukla, Dr.
much.
Molina, Dr. Madhu. Thanks for the participation and wonderful content which you have given for us. And we hope this will be a reference video for anyone who's going to dive into this aesthetic gynecology practice. So where they can optimize the solutions and where they can select the patients like in a right way. Thank you, ma'am. Thank you, everyone.
Thank you. Thank you, sir.
Take
Thank
care.
you.
Thank you.